And welcome to this special live streaming episode of The Dental Guys. I'm Wes, the Dental Guy.
And I'm John, the Dental Guy. And
John,
I feel like a 3M commercial slash Darth Vader.
yeah.
But I think,
Use the
I'm
Force,
ready to
John. Use the Force as you're using these to hope that you don't get COVID or you don't give COVID to your patients. Use the Force.
I mean, I feel like a pediatric practice, this is perfect for pediatric practice, what I have on right now.
We were talking about this the other day.
This is how you build a practice in the pediatric world. You come in wearing this, hey, how's it going, little Johnny? And they can't tell whether you're smiling. They can't tell whether you're, angry.
Mm-hmm.
And then, but you are safe, or are you? And that is the discussion today, Wes, is is it safe to reopen a practice? I can't do it. I just can't.
I can't do it either. And going back to as your Hangout phone call comes in right now, right?
Oh, that's great. Yeah.
Yeah. Isn't that great? So, John,
it's a great thing about Google Hangout.
Yeah. Hold on a minute while I take off this.
To open a practice, right? To open your practice right now, that is the big question. And I think that the question too is, what is enough? And the ADA, of course, is what we normally look to for guidance in this. But I think today we need more than just that ADA document that we all got. We need to talk to people who are true experts in this field. So I'd like to welcome back a true expert in this area, Mary Govoni. And Mary, we're glad to have you back. This is perfect. I feel like the perfect time to be having these discussions.
Well, thank you. I'm glad, excuse me, to be back. And absolutely, it's the perfect time to be having these discussions because we have to plan for reopening the practices. I'm living in fear right now that people are just going to go out and open back up their practice schedule as they normally would and conduct business as usual. And I don't think it's safe at all to do that right now because we know there are still new cases of the coronavirus surfacing. And one of the best things that I shared with you all before is that the ADA reiterated what the CDC has been saying all along is that we have to treat everybody right now as if they have COVID because we don't know who the asymptomatic patients are, or the term that I'm hearing used a lot now, the silent spreaders. We don't know who they are, and it could be anybody walking into our dental practice.
Yeah, what was the percentage, John, that we heard about how many people are they actually, because there was some testing done in some places, I'm speculating right now, and Mary, you might shed some light onto this, where they actually had enough tests available to test a group of people, whether you were symptomatic or not. What was the infection rate?
What I heard was that it was around 25%.
Whoa.
Were asymptomatic, you mean?
Right.
Yes.
Yes. True. Yeah, that's what I guess I was going to say is I've heard 80% of people that have COVID-19 are asymptomatic. So that jives with the number you threw out there, Mary. 25% of people asymptomatic carriers. And these people are highly infectious, right? I mean, from what we understand, that those people that are asymptomatic during that phase, in fact, we're hearing some reports that those people may be like their most, the most viral load in the early days where they're asymptomatic.
That is exactly right. That's what the science is showing, that is when they have the highest viral load. And so you take those patients and you bring them into a dental practice, and then you're doing aerosol producing procedures where you are spreading those droplets around in the treatment room. And it's like the worst case scenario. It's like the perfect storm for infections, not only to the doctors and the team, but to other patients in the practice as well.
So let's discuss the interim guidance first before we get into some other things. We received interim guidance Saturday, this past Saturday, from the American Dental Association. I want a little talk based on what the CDC, OSHA has, and what things like what things they've said and what the ADA has said, what are some things that are going to change, right, immediately, and who do we follow here? That's the question, I think, and what things will change from a patient management perspective?
Well, I think a lot of things are going to change. First of all, OSHA has only really weighed in on emergency situations. So we don't really know what this looks like beyond or post-COVID, as some people are now starting to call it. But I think we still have to consider ourselves in sort of this emergency situation, but we may be expanding the types of patients that we see. The ADA guidance is excellent because I think they did a really, really good job of explaining about respiratory protection. What the CDC is recommending is that we, first of all, use an N95 mask, but knowing that they may not be available, then the next best options would be a KN95, which is an equivalent to an N95, but it's not a US approved device. So in other words, it hasn't been certified by the National Institute for Occupational Safety and Health, or NIOSH, but it's a good substitute right now since we can't get a lot of N95s. And then the worst case scenario, which is considered to be a moderate protection level, not a high level of protection, is an ASTM level 3 face mask, a procedure or surgical mask. But in all of those cases, whether it's N95, KN95, or level 3, CDC and ADA are recommending that we wear face shields. So the biggest challenge, I think, right now for practices who want to be able to open back up again right away as soon as they can is the first thing they have to do is make sure they have the appropriate PPE and they have enough of it. Now, the CDC Interim Guidelines also talk about changing protective clothing after every patient. So that would be a big change in dentistry. And it's interesting because way back when the bloodborne pathogen standard was being promulgated and a number of experts were testifying before OSHA committees, OSHA originally wanted us to change our protective clothing, so a lab jacket, lab coat, scrub jacket, or have a disposable gown that's changed after every patient. And organized dentistry and a lot of people said, oh, wait a minute, that potentially provides an opportunity for cross-contamination, especially from sleeves. And many people said, okay, the better thing to do would be to wash our forearms, our hands and our forearms in between patients and not cross-contaminate. And OSHA said, yeah, but that's we're not about patient protection, which is true. It's employee protection that they're charged with. And they said, no, we want those long sleeve garments. And so when we said, oh, wait a minute, what about the expense? You look at an orthodontic practice where they schedule so tightly, how in the world do we even have time to change our clothes in between? And so OSHA then said, okay, then change the garments when they become visibly soiled with blood. So that's kind of where we ended up with OSHA, and it's been that way since 1991. Is it the best thing? Probably not. Not from a patient standpoint and not with this very highly infectious virus. So if we had droplets on our clothing and the patients, touched it and touched their face, which isn't such a likely scenario, but that is something that's being recommended right now by CDC as we change that clothing in between patients. So then there's the trickle down to how often are we going to schedule patients? Can we schedule back to back to back in the same operatory? And the answer to that right now is probably not. And I keep thinking about what Anthony Fauci says is that when we open many businesses back up, that we don't go from red to green, we go from red to yellow and we stay there for a while and then we go to green. So I think that we need to look at scheduling fewer patients and having a little bit longer time in between, because unless we have mitigation systems to control the aerosols in those treatment rooms, we know that it's possible for aerosols to stay active in the air for up to 3 hours. And COVID's been identified in some of those aerosols for up to 3 hours. So life as we knew it in scheduling and PPE is over now, and we need to start with a new normal.
Wow.
I know nobody likes to hear that.
Well, no, I mean, it's not, nobody wants to hear it. You're right. But we have to be able to hear what's the truth here. And I think this ADA document it really doesn't go through much at all of what you just said. It's a little vague. A single page, and it essentially just says, here's they want to be clear that N95 produces the lowest risk, and surgical masks produce a moderate risk of transmission. And then in the fine print, of course, it says liability issues essentially are still a thing. So you need to be aware of that. But there's not a lot of discussion about all of these other things you mentioned, because this essentially is, you have to blend what the ADA is saying along with what OSHA, with what CDC is saying. Do you look at that ADA document as what if your state is going to reopen? Let's just kind of get down to like the bottom line here. If your state is going to reopen, and let's say you're in a state that's going to reopen, May 4th might be a day that some dentists will be going back to practice. When you look at that document and you try to interpret what that means for a practice, obviously that is saying that it's not saying you can't see a patient without an N95. It's saying you just have to be aware of the risk. But when you take into account the CDC and OSHA guidelines from especially the emergency patients, it sounds to me like you're saying that minimum requirements are going to be changing gowns or changing some type of disposable gown, having face shields in place, considering controlling aerosol, but then what do we take from this ADA document as far as the masks? Before it sounded like we shouldn't go back without N95s. Is that still the case, or are they trying to kind of open the door for it's okay to see patients with surgical masks, do you think?
Well, what the ADA is doing is very closely mirroring what the CDC guidelines say. And just to clarify, there still are many people out there in dentistry who believe that CDC guidelines are voluntary, and they're really not, because many state dental practice acts incorporate CDC guidelines as the standards of care into the dental rules. And so you do have to follow them to be compliant with your state dental board rules. And their focus is primarily on patient safety standards, but they also address occupational safety as well. And the CDC has been updating information, but we haven't really seen many updates. We've only seen one update from OSHA, and it was their guidance on preparing the workplace for COVID-19. And they essentially refer back to CDC guidelines on PPE. So we also have to, and I don't mean this in any way disrespectful to the ADA, but they're not a regulatory authority. So we really have to go back on what do state dental boards say about, when can you go back to practice and which guidelines should you follow? So I would tell practices, I tell everyone I work with, you need to follow CDC interim guidance on what to do. And so if we don't have anything more definitive than we have right now from CDC about controlling aerosols and so forth, it's really more about PPE and screening patients, then we have to follow that for the near future. So because we're still in the middle of the pandemic, we haven't declared the pandemic over. So need to follow that for the time being until we get new guidance from CDC, until we get new regulations from OSHA. And that may be maybe several months before we get that. So the CDC has acknowledged, and so has the Food and Drug Administration through their emergency use authorizations. They will say that N95 should be what we're wearing because it's the best protection. And it's not so much about the filtration from the masks, it's the seal. So if you look at a surgical mask, there's gaps on the sides and there's gaps around the top and the bottom where aerosols can get in. With an N95 mask that seals tightly around your face, the aerosols can't get in. So that's why there is that recommendation. In fact, you've probably seen even on the news some of the pictures of the healthcare workers that don't have a properly fitting N95 mask, and then they have bruises all around their face because it's pulled so very tight around their face. So masks and face shields, we know we've got emergency sort of dispensation to wear those. N95 the best, level 3 not the best, but it's so dependent on supplies right now. If we can't get them, then we got to do the best we can.
Okay, so let's hold it right there, because I think we have to say, for the most part, I mean, all of my distributors, I mean, for goodness sakes, they do not have these available in any shape or form, in any quantity that we could possibly do. If you look at the number of patients that I have to see within the first month, let's just say it's 700. John, I think you're probably close to that, you know, trying to catch back up. We don't have 700 masks. We don't know when 700 masks are coming. So what you're going to say, Mary, is that I'm going to opt in for a level 3, right, which is what I'm holding up on the screen right now, okay, surgical mask. And you're going to say, well, that's moderate risk. And you're going to tell your patients we don't have N95s. Okay, so you're going to come and get your tooth cut on and your teeth cleaned, and all the things are going to get done just like they were before. We don't have
with a face shield, though. You do have a face shield,
right? With the face shield and the gown. But I'm talking about breathing here, John. Okay,
right?
And so if we go back to work in our state, you know, here in a couple weeks, we're going to be wearing these, right? Unless something changes. Now,
well, or the K95s, because those are available through many distributors.
Really?
That's
I guess I was
Yes.
checking and I didn't see them, but I'll have to look again.
Yeah.
Well, and again, because we have these emergency use rules, you don't necessarily have to buy them from a dental distributor. And no disrespect to our partners in the distribution area of dentistry, but you know, this is any port in a storm. If you can find them that are, you can.
But let's say that you can't find them, right? Because everybody and their brother wants to go back into work. Are we saying that the ADA is saying, based on the interim guidance, use what you've got, and if you've got a level 3, then you're doing the best you can?
Well, we're in kind of a catch-22. It appears that that's what the ADA is saying, but the CDC interim guidance, keep in mind, is for seeing emergency patients during this crisis. So they're saying that if you absolutely have to see a patient and you don't have an N95, here's a couple of alternatives, but they have not addressed that up to now in terms of seeing patients on a more regular schedule or seeing patients for elective procedures. So if you had any supply at all of N95s, another option is to have that N95 mask, and rather than have it be disposable, you put a surgical mask over the top of it and protect it from contamination. So then you could reuse it, but you would also have to be very careful about how you are removing and adjusting. And so you might need to have that N95 mask on for long periods of time, and then you're replacing a surgical mask from the outside that's protecting it from droplets, from spatter.
But assuming we don't have, and I know the ADA has said that they're going to put out more guidelines. That's what we have heard. So hopefully that'll clarify this. But it's important I hope so. That would be great, because I think that's what we need. Because as you said, this is all still kind of in the emergency mode, emergency patient mode. And the question is, what's the minimum for treating the elective, prophy patient? Is it okay to say we don't have N95s, we don't have KN95s? If we don't, and we're going to use a face shield and a level 3, is that going to be considered acceptable for where we are? Because it is acceptable for treating emergency patients, with the understanding that there is still a risk. But that's hopefully coming from the ADA. Hopefully we'll see. And again, not like the ADA is regulatory. So they could say, hey, our guideline, our recommendation is that you wear N95 for every patient, no matter what. They could make that recommendation, but still it would come down to whether or not OSHA or CDC or state regulatory agencies would actually step in and mandate that, versus kind of saying, use your best judgment.
Right. And we just simply don't know that. I know that the ADA works very closely with the CDC. And so I'm sure they will make every effort to get the guidance that they pass on then to their constituencies will be based on CDC documents. And they work closely with OSHA too, and to look at issues coming from OSHA. The concern that I have right now is with team members who are very afraid. They know this information. They know that, and many doctors, of course, are concerned as well, that if there is a moderate risk and we're still in the midst of this pandemic, do we take that moderate risk, or do we wait until we actually have the best PPE that we know is the N95 or the KN95 to control that risk better? And it's something that everyone's going to have to use their individual professional judgment, but also balance it with what's the risk? What is the risk to the dentist? What's the risk to the team members? And then, of course, equally important is what is the risk to other patients if I schedule so many patients so tightly that I don't have a lot of time for example, air exchanges to happen with the HVAC system in the treatment room. So I see one, right after another. And I don't know that that's necessarily appropriate at this time. So there's still so many unknowns.
My wife is a dental hygienist, and today a dimensions in dental hygiene thing came out. And basically, if the minimally acceptable combination of surgical mask and a full face shield is not available, we know this, do not perform any emergency dental care. Now, we know that kind of thing, right, exists, because that's this interim guidance. And it says refer the patient to the clinician who has the appropriate PPE. So what we're hoping for here is that kind of definitive guidance from OSHA and the CDC. And we are expecting to see that come soon, are we not? Because that's the kind of information we need to know.
Well, that information comes directly from the CDC interim guidance. So that's where that comes from. So
that's already out there, right? Saying you can't, that's essentially where we are now.
My point is, John, is that we need that kind of guidance. There's not right now.
We do. And I don't know that we're necessarily going to have that.
I didn't want you to say that.
In time for some folks to open up. I know I'm hearing, May 1st, that it's okay in some states to go back to practice. I had a long conversation with one of my clients in Texas this morning, and the determination for that practice is, no, we're not going to do it if we don't have the right personal protective equipment, because it's too risky at this point.
So one of our listeners
everybody
that
wants
listen to this.
Answers.
Yeah, everybody wants answers. I don't feel like we don't have them. We don't have the complete answers yet.
No,
right?
We do not.
And we're just waiting. So, John, you know, it's like you said in many texts, it's survival of the fittest, right? It's survival of the
That's what
fittest.
we have right now.
Because if you're a dentist, one, or a team member that isn't the healthiest person in the world, right? You have to ask yourself, should you be practicing without the highest level and lowest risk possible? If you're a patient and you go to the dental office and you consented to be treated, and one, we don't have any formal guidance on what questions we should be asking patients at the door right now, right? Mm-hmm. We don't have that. I'm not a physician, right? So what from the ADA do we have whenever we screen patients, and what is that going to look like, Mary?
Well, the ADA actually has a document on screening patients, and the CDC has some guidance in those interim guidelines as well. And so it really centers around, do they have any symptoms currently? Do they have a fever? Do they have contact with, or do they live with someone currently who has been exposed to COVID or is recovering from COVID? There are a whole lot of questions. And so if we can, at the end, I can give my email address, and I'll be happy to share those questions with the listeners. But yeah, we do have some of that. We do have a recommendation from CDC that we take temperatures of patients when they come in, with a non-contact thermometer. So an infrared or some device that doesn't touch, you just run it across the patient's forehead, or you aim it at the patient's forehead. But that we also do this pre-screening of patients when we're confirming or when we're scheduling. And so if the patient answers yes to the questions that indicate potential risk of having been exposed to COVID, which means then they are potentially infectious, that we don't see them. That we don't schedule them for at least 2 to 4 weeks from the time that they've reported a potential exposure or something of that nature. So we need to do a lot of screening of patients. And I think that this is the time when the team members need to go through some training to get comfortable with asking those questions, because they, of course, in looking at being efficient and knowing that patients don't always answer questions or completely when we ask them, that they need to be well-versed and comfortable asking the questions, and then telling the patients that, no, we can't see you at this time, and facing, the wrath of the patient who says, I have to come in. Now, we still would see emergencies, as we have been, but elective procedures, we've got to be screening those patients to make sure that we're minimizing the risk as much as we can. And then doing things like clearing the reception area of items like toys and magazines that couldn't easily be disinfected, having patients use a hand sanitizer or wash their hands with soap and water as soon as they come into the facility. And there even are some suggestions out there, and there are some in one of the ADA documents that's available, about having patients check in from their car, from their cell phone when they arrive. And then we only have them come into the office when we're ready to see them, so they don't spend time in a reception area. We take them directly to the treatment room. So we do have some of that guidance there, but that's going to be such a behavioral change for us that I think now's the time to start preparing for that and defining what that looks like, and making sure that every team member gets whatever the protocol is established for that practice in writing, that they can refer to it, they can digest it, assimilate it, be ready to implement it as soon as patients are coming back in.
So as it stands right now, to kind of conclude up on just PPE and what we know, I'm going to ask you, if you, in your state, where are you located at, Mary?
I'm in Kansas.
Okay, so in Kansas right now, if you owned a dental practice, or you were advising someone that owned a dental practice, right now, if they don't have KN95s or N95s, and they needed to open tomorrow, or they could open tomorrow, let's just say that, what would you say?
My advice is that you're not ready. to see patients. If you don't have the very best protection for yourself and your team in terms of respiratory protection, then my advice would be to wait. And wait until you have the appropriate supplies. Because team members, I hear from team members all the time that say they're terrified to come back to work. If they don't have N95s, they don't want to be working. They don't want to perform procedures. So you never want your team members to feel that you're not protecting them or that you don't have their best interest at heart. And you don't want to alienate those team members. And in the doctor, nobody wants the risk of potentially being exposed.
Yeah, I think that's what, what comes up sometimes, I think, or what we kind of keep hearing is what makes this different than, the kinds of things we've been exposed to over our entire career. And I'd like you to kind of speak to that a little bit, because sure. I think it bears repeating, what's different about this virus versus flu or other conditions which are also spreadable through aerosols. Speak a little bit to that about what is different about this in terms of why should we be concerned?
Sure. The two main reasons why we should be so concerned is that we know that this virus is so easily spread. And the numbers of cases that we see are, of course, testament to that. The other issue is that we don't know who the infectious people are. That factor of, or that characteristic of these patients, that they may have been exposed, they may be a carrier, they may be infectious, and they have no idea. And now the new information that we have, that's when they may be most infectious, is probably the scariest of all. So we don't know who these people are. And that's what differentiates it. Somebody who has the flu is not highly infectious until they're already having symptoms. They're coughing and sneezing and they've got a fever. That's when they're infectious. But we also have had a number of outbreaks in the US of measles. Measles virus it's a respiratory virus. Many people think of it as just, the kind of skin rash and the fever, but it's a respiratory virus. And you can have patients who are just at the very beginning stages of a measles infection. They don't have any other symptoms other than maybe just kind of a runny nose and a little bit of sniffle. They're already infectious, and the measles virus can stay airborne for 2 hours. And the particles are small enough that they can get taken up into the HVAC system and then get recirculated. So that's an even bigger risk, although we have smaller numbers of people who are not vaccinated. But in many ways, what we're now looking at in terms of airborne infectious diseases is what we really should have been looking at all along, but we haven't had anything that has such serious effects on patients. And you keep hearing the statistic, well, 90% of people recover from this virus. But I think we're going to see that even though many of those people have recovered, they still have some lasting effects. And we still don't know everything that we need to know about this virus because it's new. We don't know all the issues.
And I think that it's interesting. And I would, if you're, if you want to read about this, obviously CDC has a ton of stuff. If you want to listen about this, I'll actually, and Wes knows what I'm going to recommend. I actually recommend a couple podcasts by Joe Rogan. I know this sounds so silly, but he had really smart people on, Michael Osterholm and Hotez, both people that are very, very well respected in their fields, that talk about the difference between this and SARS and MERS, and the reason that SARS was so easy, for instance, to control was because, as you said, when people got sick, they were sick. And so they could immediately quarantine that person. They could immediately know, hey, this person's got the virus. This person, you can put them in an isolation situation. And it was easier to stamp out. The same with MERS. And so this is in the same line, but you don't know these people are sick for a while. And you also have the potential too of the type of disease that this is creating, affecting people in a pretty massive way. And obviously these other diseases did that, but we've never had a situation where somebody could walk in and seem fine. I think the game changer here is going to be widespread testing. I think that's the thing that changes the game for us, is if we have widespread testing, now the PPE question, because everybody's so worried about PPE, and I think it
lowers the burden.
It's good to talk about. But if we have testing that is even like point of service type of testing, which I think is the future then it's going to change a lot of those requirements. We're no longer going to have as many worries about that. But let's talk about engineering controls and some of the other things we can put in place. Because I think one of the things that we keep coming up here with is aerosols. And what can we do? What types of products are available? There's so many things that we've been using up till now that really it wasn't necessarily advertised to control aerosol, but can control aerosol. And then there are some new products that are coming out, or things that have been out but haven't been widely used. What should we be looking at if we want to control aerosol? And in those maybe discussions, is there any actual testing of these devices, or is it kind of more based upon, expert opinion? What should we be looking at if we're going to invest in things to help to control aerosols?
Sure. One of the recommendations that the CDC has been making for treating dental emergencies is control the aerosol as much as you can with, high volume evacuation, using a dental dam, a rubber dam, which isn't as widely used outside of some specialties. In pediatrics, a lot of times they're used. In endo, of course, they're used, but not as well in general practice. But using a dam really blocks the saliva from being aerosolized. So that would be a great way to control it, and not a huge investment in equipment, but it's an efficiency thing that in many states, the dental assistants with some training and or some credentialing are able to apply the rubber dam so that they could have the patient ready for when the doctor, is going to go ahead and do a procedure. But it's also not applicable in every restorative procedure. So then you look at other types of evacuation devices. The ISOVAC system from Xyrus is one that can be used sort of as a mouth prop, keep the mouth open, but it attaches to the high volume suction and helps to control that aerosol. Plus an assistant also using a high volume evacuation where you really focus in. Some of the devices like the Leaf or what is Mr. Thirsty from Zerk. I love those devices, but if they're not available to, some of them are just for using on the saliva ejector, which is a lower volume suction. I think Mr. Thirsty can go on the high volume suction. I don't remember.
It does. It goes right on the high volume.
And it's A-okay. It helps. So if you're using those kind of devices, but what's being talked about right now, and you may have read in the interim device, excuse me one second, allergies, not COVID. In the interim advice from, I have to clarify that because people freak out. Right. Interim advice from CDC, they will say that, or not from CDC, from OSHA, they talked about only treating dental emergencies in negative air pressure situations, which then means a hospital setting. Negative air pressure isn't possible in a dental operatory. So in lieu of that, what we're kind of hearing that OSHA, and again, we don't know for sure, but it's possible that OSHA may look to extra oral suction devices. A company called ADS Dental Systems has a unit. It's portable, that has an arm on it with a focusing cup that you position near the patient's mouth when you're working, and it really controls that aerosol. It I would venture to guess, doesn't let much of anything escape into the room air. And they've got lots of data showing how much it controls those aerosols. And I think that that's maybe where we're going in dentistry right now. It's probably not the most cost efficient, because those are several $1,000s for those units. And I don't know if they're even available to everybody right now, because of course it's, everyone's going to want to be ordering them to get them ready for when they see patients. There are a lot of companies now that are marketing air filtration systems. And my advice on that is buyer beware, because there are some companies that are saying that they're certified to kill COVID. And I've looked at a couple of them and I can't find who actually has certified them. The agency from the US standpoint that we would want the certification on would be NIOSH, the National Institute for Occupational Safety and Health. They certify our respirators, they certify other types of air quality devices. So one company also will say that they're certified to kill SARS, and because COVID is a SARS virus, that it will kill COVID. Well, I don't know that. So we have to be careful about what claims that these devices are making, but there probably is some benefit to them. So that's another one of those waiting game things until we know for sure. But if it were me and it was my practice and I wanted it to be a good, safe, healthy environment, I would invest in those extra oral suction devices so that I know that whether it's this SARS-CoV-2 virus that causes COVID or it's influenza or whatever it is, I'm controlling that aerosol, and it makes a better, safer environment for my patients and for my team.
Yeah, I think that's a good point. I think there's a lot of things right now that we're trying to kind of battle. I think you made a good point at the beginning there, and you said, hey, the very simplest thing you can do is start using a rubber dam if you're not using one. Yeah. If you don't even, I mean, we've all got rubber dams in the office, and it's a standard of care for certain procedures anyway. And then as far as there are these things that John and I've talked about on the shows. One of our products of the week has been, the Xyrus's Isovac Isodry.
Yes.
Those are excellent products. They're super cost effective, and you can really set that up to where you can really just rock and roll with patients, and it works great with kids. And then an even more cost-effective manner is exactly what you mentioned, which is Zerk's Mr. Thirsty. John and I've reviewed that product, and it is a great product as well. I think you start there, and then you kind of start thinking, okay, where is this going to go from here? And I think some of those in-operatory devices that reduce the aerosols, I've seen and been a part of some operatories that have those, and they are really legit and work very well.
But my question is, though, here's the other side of that argument. Okay, so again, right now we don't know. I mean,
that's right,
we're
John,
saying
we don't.
we're saying that, but we don't actually have. We don't know, because a lot of people are going to say, okay, those are $2,500 a pop for those units. And so, if you've got a decently sized practice, you could be dropping $25,000 into these. And I know you don't maybe need one for every room. Maybe you can have mobile versions of those. You can move them around. Right. But I think a lot of them, it's going to be more difficult to move them around. So let's just say it's a $25,000 investment. Do we need it? And then second off is, because we don't have specific guidance on that. And then if we have widespread testing and we can identify who has this or doesn't have it, do we even need that anymore in our practice? I'm not saying it's a bad thing. I'm not making that argument at all, but it's always now we have people that are seriously on the ropes right now financially. And now we're trying to have this discussion about, well, how far do you have to go? And is it something we're going to look back on in a year and say, wow, I shouldn't have spent $25,000, just like all the manufacturers of masks, or are they going to be sitting on, 10 million extra masks in a warehouse that they're going to be, I'm not saying it's bad. It's just, that's the counter argument.
Well,
to this
now it's a moot point, John.
Really to have, you know?
It's a moot point right now because we don't know, okay? But what we do know is that we can do some things that doesn't really cost us anything up front, and it's been around for a while. Now, my question for Mary is, most dental offices are single doc or maybe a doc and a half practices, 2 hygienists, and then you have really this open operatory design that's kind of really been, and even an open reception area design that's really been like super mod and had started to kind of come into the practice design space really back in the year, like when I opened my practice, people were moving away from the sliding glass doors to make it feel more inviting. We have open areas as far as payment goes. So it's a very open environment, right? And so the question I'm going to ask, Mary, is that do we need to protect the front office in any way, shape, or form in these open office designs?
Well, I think, again, in the interim, while we know we're still in the middle of this pandemic, yes, we do. The business team members are not going to be directly exposed to the aerosols like the clinical team will be, but they, for at least for the foreseeable future, should wear a face mask. I know some practices that have ordered sneeze guards that they can put up. You know, I've seen them at Starbucks, and you see them in the grocery store checkouts, those types of things.
You're talking about like the plexiglass type of
plexiglass. Yep, exactly. Yeah, okay. But at the very least, the business team members need to be wearing a face mask when they're interacting with patients, because even if the patient went directly from their car to the reception or to the treatment room, they're still going to have to interact with the business team, the patients will, to check out when they leave or to reappoint. But you know, it's so interesting that we went to that more open design, and then the HIPAA rules came out, and then that wasn't so friendly to privacy for having patient conversations. And I think there have been a lot of practices that have been thinking about, okay, now what do I do? Because I've got this open area, patients can hear a lot of things. And now we have this on top of it. And I understand, you know, everything that we just talked about, that, we don't know what is going to be required. But I think beyond what is required, because many times people will say, well, I'm going to do just the bare minimum. I think right now, because there may be, we don't know yet, but there may be a lot of patients reluctant to come into dental practices because we've been portrayed out there as this high risk profession because of aerosols. And the scary thing that I heard on the news the other day is that they're finding that a lot of people are dying at home now from heart attacks because they were having chest pain, but they were so fearful of going to the emergency room at a hospital now because of COVID. We may see that with patients. They may have some pain, or they may know that they need to, you know, have their continuing care visit, but they're afraid to go. So I would look at, if this were my practice, if I have some kind of an extraoral suction device, then that becomes part of my marketing strategy to patients, that this is COVID and beyond, having these devices, that we're dedicated to reevaluating safety issues in the practice. And we now are concerned about the potential for spreading not just COVID, but other potentially infectious airborne diseases. And so this is what we've dedicated ourselves to doing. And I don't think that because we invested in them now, we don't need them later on, because everyone says there will be something that comes after the SARS-CoV-2. What's the next type of disease that's going to come along?
My concern in all of this is that we're not going to get guidance. We're just not going to get it.
Oh, I think we will.
And I just don't think that we're going to get clear, because you know why? Because there's too much money involved, right? I mean, I'm just going to say it. I mean, that's a political statement, or, you know, John, we've talked about that, is that, you know, people have to make money. And I think what's going to happen is people are going to open up, right, without the personal protective equipment that even, you know, recommended. And now that could be a problem. I mean, I'm just a little concerned that people won't next level right this, and there won't be any science even to show what we're doing is right. Right? I'm a little concerned.
Because it's going to take time to even know. I mean, we would love to see the guidance, you know, and I'm glad to hear you say that you think we will get that. You know, that this hopefully is just interim. You know, they're going to be more specific on that. But, you know, as it is now, I mean, if you look through all the recommendations from CDC, essentially it is use the highest level of personal protective equipment available. That's the word, available. And so you're going to have people that say, hey, I Googled it. I couldn't find anything. It's not available. And so they're just going to go on. But in the background, people are thinking N95s are $4 or $5 a mask. And so how hard are they going to look? If there's not a specific guidance on that, they're not going to look very hard. No. And all you have to do is go onto your dental supplier website. If it's not in stock, they're going to say, well, it's not available. CDC guidelines say use the highest level available. Highest level available currently is what I have, and I'm going to see those patients. And that's what we're concerned about, is that we won't necessarily have that. And I mean, to be fair, again, we do have to operate a business, and there are people that I know are in trouble. And that's the challenge, is trying to balance all that. But you feel like we're going to get some more definitive guidance on saying, hey, for elective procedures, this is what you are going to be required to have by not just ADA, but by CDC and OSHA?
Yeah, I do think we'll get it. The question is when. And I think that again, OSHA and CDC are really taking a good hard look at all of this right now. But since we haven't had until just the last week or so any idea of a date for reopening practices, and CDC has said that, you know, even though they have said, I believe their guidance was April 30th. But they said then that's when we have to go back and we have to reevaluate where we're at. And part of that is going to be whether we have the appropriate PPE available to have that maximum protection. Because what you absolutely is, and I totally understand that whole idea of that, you know, there's a business that needs to have needs to be producing revenue in order to survive. But the worst case scenario would be that we open prematurely. We don't necessarily have the best protection. We have what's considered to be good enough. And then we have an outbreak traced to a dental practice. And that will have such horrible consequences on the practice, more so than staying closed for several more weeks in order to get the right PPE in place to protect them.
That's what everybody really,
if the states though don't enforce that, right? So if your state says, hey, you guys can go back to work, what do you do if you're a business owner of a dental practice and you don't, if you don't feel good about whatever part of this there is, either it's lack of guidance or you don't feel good about the PPE or whatever it might be? I'd like to think that dentists will just hold back, but I don't think that'll happen. I think people will go back to work, and I think that it'll almost be like one of these local standard of care types of situations where people say, well, if there is somebody that gets sick, is it just going to be, well, hey, everybody's doing it? You know, everybody's using this type of approach, and will people just appeal to the local standard of care being the standard of care with absent that specific guidance? And then what happens if OSHA and CDC comes in, say in 2 weeks, and they say, you got to have different PPE? I mean, are we going to have to shut back down again? You know, that's, I mean, I just imagine that being such a challenging thing as a business owner to see, because patients don't understand this a lot of times. Like if 9 out of 10 practices go back to work in your town and you're the one that doesn't because you don't feel good about it, you can do that. Of course you can do that, but it's hard to get across what, you know, are are you just fear mongering, right? Are you just afraid to go back, or are you maybe sick, or, you know what I mean? Like, that's the thing we're going to have to figure out, is how do we put that out? Is the ADA, or who is it that's going to do a good job of kind of getting that out to the public, that we truly are concerned about their health, and it's not that we're trying to create a fear situation.
Right. And I know that because the ADA has done such an amazing job of getting information out, I think that they will give some guidance on how to communicate that to the patients. But I think the patients, for the most part, want that margin of safety, that if you didn't feel that it was safe to see patients and you communicated that to them, that we're going to wait just a little bit longer unless you have an emergency, because we want to make sure that we protect you as best we can. I think that's what most patients want. And I think we're going to probably be about evenly split. I think about 50% of practices will say, hey, good to go. I'm just going to go see patients. I'm allowed to see elective patients now. I'm just going to do it. And then the other half, I believe, will just sit back and say, wait a minute, I don't really have the maximum protection, and I don't want to have any issues. And I honestly think that there's going to be practices that are going to really have to sit down and have the, as I call them, the come to Jesus meeting with their teams, and really gauge the temperament and the level of fear that the team members have, because they are not necessarily feeling so much of the pressure that the doctors are to get the practice open, because they're not the business owner. But many of them feel that they're at great risk, and they're going to be reluctant. I think there's going to be pushback from many team members. And so we can't just, as a lot of people are saying, flip the switch and open back up. There's a lot of training, I think, that needs to be done to get the teams comfortable, as I said before, with screening patients, but really to allow the teams to voice their concerns. And how do we allay those fears and help them feel confident that they're coming back to a safe workplace?
Yeah, that's probably the top thing right there, is you've got to have a team meeting here. If
you do.
Care, and I think, too, is that there's these things, and there's this thing called liability. And you said it earlier. We're going to come back to this, and this is how we're going to kind of close out the show, John, because it's going to lead to our next show, is there's a certain amount of things that we don't want to happen. And I'm going to tell you right now, the thing I don't want to happen is, one, I don't want it to come back and say that somebody got COVID and died in my office.
Absolutely.
Now, here's what would happen if that would happen. And it would go viral, right, on media, and we would be painted in a light. Now, here's what could happen. If you're saying that 50% are going to go back and just do whatever, right, which is probably true, right, we might have that situation. Now, what's going on right now behind the scenes, Mary, about, like, what have you heard about the legal liability? We know that the ADA at the bottom of the sheet, right, John, it says this, you are liable. Right?
Yes, you are.
You are liable, right? So that means you could be sued, right?
Yes.
So what's going on behind the scenes right now as far as, like, malpractice insurance and this liability of if someone does get sick or just gets sick and loses work because of this, much less dies. And then on top of that, what if one of your employees die, right? I mean, what's going on?
Absolutely. Well, I think the liability, and I've been saying this all along, I think is huge, because if there was guidance in place that the maximum protection that you should have, the very best respiratory protection you should have, is an N95, but here's something that's moderately helpful, like a level 3 mask and a face shield, and we opt for that, then if somebody was inclined to sue you because they alleged that they got infected in the practice, whether it's a team member or whether it's a patient, then the only option I think for those attorneys to do would be to go and attack you for, why didn't you provide the maximum? You knew that that's what it was, and you chose to do this. I think it's an absolute no-win situation for a dental practice in terms of liability. And not to mention, like you said, it would go viral. Thankfully, we didn't have all the social media in place at the time we had the HIV transmission from the dentist in Florida to those patients. Mm-hmm. It would have just caused such a firestorm like it would now. It would be viral in a minute. You would have patients never wanting to come back to the dental practice for a very long time. It would just be a horrible, horrible thing. So as hard as it is to not have that revenue coming in and to want to go back and open up, I think that we really have to err on the side of caution and wait and see what the guidance is. And if you have N95 masks and you can utilize those, then yay, then you could see a limited, number of patients. But boy, if you don't, I think it's such a big risk to take.
Well, I think that this has been great. You've answered, I think, the questions that we're all asking. And, the thing about this type of situation is there's no easy answers. And I think that's what we've kind of discussed today, is there are no easy answers. This isn't something where we can just say, hey, this is a simple fix. And we've known that, I think, especially for the last month or so, that it wasn't going to be a simple fix. And in the end, we have to balance it out between, as we've said on the show many times, being a business owner and being a healthcare provider. And we always have to make sure that first do no harm is the thing that we emphasize in our practices, and that we want to be taking care of our people, whether it be our teams, our staffs, our own families as well, and not, bringing things home to them that could, and I think it's interesting because and I just kind of leave it with this, the people that I hear that are maybe taking this the most seriously are the people that are in areas where they've had huge outbreaks of this disease and they've seen people die. They've known people that have died. They've had family members affected. It's much easier for us maybe in places where we haven't had as much of an effect to not really feel this in a way that we almost kind of want to not think about. And we also have a business to run, and there's a real fear. We talked about almost a month ago, it's been 3 weeks ago now, the scarcity mindset, the fear that a lot of practices are feeling right now, the what if scenarios. There's a legitimacy to that. And it's a real test for leadership in our profession and in our individual practices. And, we're trying to do the best things that we can. And I think anybody that's listening to this is in that same boat. I appreciate the fact that you're, able to help us to understand how to do that, to lead and to do the best that we can. So I think, take home messages from today for me are hopefully we'll have some specific guidance that'll tell us exactly, so we don't have to ask these questions. So we don't have to ask, what should I do? I think that's the key. If we have that, it changes a lot of things. Second of all, let's all hope and pray for testing to be widespread, to where a lot of these PPE questions become secondary. And I think that's coming. And then, of course, we hope vaccinations coming. All these things will change the game. But for now, I think we need to stay tuned to, our organizations and encourage them to continue to push our profession to be a leader in this. And I think we have a lot of ways that we can be. So thanks a lot, Mary, for being with us today. It's been great.
Thanks for having me.
Yep, absolutely. So if you've enjoyed what we've said, and I know that, this is a controversial topic, and we appreciate all the comments that we've gotten today, some that are, questioning some things. And I think that's good. I think that's part of, discovery is questioning. And, it's okay if you don't agree with everything that's been said. That's actually part of why we do what we do. It's not just about saying we know everything. It's about, putting these questions out there for people. But if you liked what we're putting out there, give us some good feedback on that. Give us a 5-star review on Apple Podcasts. That's super helpful for us to get our message out. Share this with your friends. I think everybody's asking these questions right now this week. So get it out there. Hopefully it helps people to guide them in their decisions in their practice. We'll be back later this week with more content along these same lines, talking about liability, talking about PPE, hopefully with even more information available by that time. Thanks again for tuning in. For Mary Govoni, for Wes, I'm John, and this has been another episode of The Dental Guys.